Thank you, Chairman, ladies and gentlemen. Yes, it's my great pleasure to review these three abstracts for the meeting. These are my disclosures. And thanks also to the presenters for sharing their slides with me in advance of today's meeting. The ESMO guidelines, in many respects, encapsulate the challenges of treating patients with colorectal cancer. So, for example, not all the patients are the same. I mean, we have a situation where we may decide that best supportive care is the appropriate option. We may decide that patients need maximal chemotherapy to try and downstage the tumour for surgery. We may also feel that these are patients who are suitable for chemotherapy, but probably wouldn't tolerate more intensive treatments. Or maybe it's a patient decision. They don't want to have combination therapy, they don't want to lose their hair, they don't want to have neuropathy. The Pan-Asian updated version of the ESMO guidelines also essentially review the same options for patients, but include the recommendation that, for example, left-sided tumours should be preferentially treated with an EGFR inhibitor, and that right-sided tumours should receive a doublet or a triplet with an anti-angiogenic drug. Interestingly, and this is where the third presentation is relevant, there's no recommendation for a triplet plus an EGFR inhibitor in left-sided tumours, because those data don't really exist. In a way, Eric's paper is the easiest to interpret. This drug, trifluridine tipiracil, I mean, it's a 5F, it has a 5FU-like effects, but it is a different drug. It's a nucleoside analog which inhibits thymidylate synthase, but also gets incorporated into DNA, and is combined with a thymidine phosphorylase inhibitor that prevents degradation of the drug. So there are key differences here. And we actually know from colorectal cancer refractory disease that it prolongs survival. It may be a very modest impact, but these are in patients who are 5FU resistant. And also yesterday we learned that this drug is also, for example, active in 5FU resistant upper GI cancer. So one of the questions that this study was posing is, what's the role for this agent in early disease? And Eric mentioned the trial that we conducted and published in 2013. A very straightforward study, patients over the age of 70, not deemed suitable for double or doublet therapy. And we showed that in this study, adding bevacizumab to capecitabine improved progression-free survival. And actually, this is a treatment that we use, not that many patients, but a fair number of patients, and they derive benefit. It's well tolerated. The TASCO study had similar design, but didn't have age as one of the cutoffs, but was generally, I think, looking at a similar patient population. Nicely designed, a simple question. What's the addition of bevacizumab to trifluridine within this clinical context? The primary endpoint was progression-free survival. And as you learned, the progression-free survival was nearly significant, but not quite. And that's probably because it was a randomized phase 2 with relatively small numbers. And again, across all of the groups, there was a benefit from the trifluridine combination. Interestingly, in the multivariate analysis, the treatment effect for PFS was in fact significant, but this is part of a multiple analyses and serves as, I think, a strong indicator that this combination is effective. And of course, as you heard, there's a difference in the pattern of toxicity between trifluridine and capecitabine. Notably, trifluridine suppresses the bone marrow. Notably, capecitabine affects the skin and causes plantar palmar erythema. So it's a choice here between differences in toxicity. So in conclusion, I'd say that in this particular study, trifluridine tipiracil appears to a promising alternative first-line treatment to capecitabine and bevacizumab in patients unsuitable for doublet therapy. And a confirmatory phase 3 study would be desirable and would give us a better idea of whether this regimen is an improvement over capecitabine and bevacizumab or is similar. Now, moving on to the CHARTA trial, the background to this is that chemotherapy doublets have been compared to chemotherapy triplets, most notably in the TRIBE study published in NEGEM, showing a significant survival advantage. But other supportive studies, Olivia, the STEAM trial, which is actually a sequential study, FOLFOXIRI then compared to FOLFOX/FOLFIRI sequentially, changed every 4 weeks, and FOLFOX/bevacizumab, both showing that the trend is always the same, and the triplet does do better. The quantum varies between trials, and the p-value varies because of the number of patients randomized. The CHARTA trial is another example of a study evaluating doublet versus triplet. Just to remind you, across the TRIBE trial, one of the most interesting subgroups was indeed the BRAF cohort, where the survival was improved, albeit not significantly improved, because of the numbers of patients. But so much so that if those of you who are at Dr. Artrea's review yesterday, an excellent review, in which she was recommending a triplet where possible, combined with an anti-angiogenic drug in patients with BRAF mutant tumors. So just moving on to CHARTA, the primary endpoint was a slightly unusual one, I would say. This was taking progression-free survival at 9 months, that's 1 point in time. And the secondary endpoints were the more conventional response rate, PFS, and overall survival. And I think if we look here, the primary endpoint at 9 months was met, but the PFS and the overall survival was not met, was not significantly in favor of the triplet. You heard that the largest subgroup of patients with synchronous metastasis seemed to benefit more than the patients with metachronous disease, perhaps once again reflecting an aggressive clinical course. The triplet in this case did not improve outcome in the BRAF mutant patients, but there were 13 patients in the trial. So we know that there's too much heterogeneity to come up with a robust analysis there. But I think that this small subset, synchronous with no resection of the primary tumor, this is again a biologically aggressive group of patients, and they did seem to benefit from the triplet. So I think that the CHARTA trial, we show that there was no significant improvement in overall PFS or survival, but the trial was underpowered to show that, but the trends were certainly there. And the subgroup analysis showed a benefit in the patients where there might be a more aggressive clinical behavior. Then moving finally on to the VOLFI trial. So this was a randomized phase 2, where the objective response rate was the primary endpoint, and PFS, survival, disease control, etc. were secondary endpoints. And the novel aspect to this trial, as you've heard, is this is combining a triplet with an EGFR inhibitor. And you can see here that the primary endpoint was met, a higher response rate in the patients randomized to the triplet plus the EGFR inhibitor. And this was seen according to tumour sidedness and according to genotype, but really these are very small subgroups where I think you can literally overanalyze subgroups in these sort of trials. I mean, I was particularly interested in that BRAF subset where you know, this dramatic increase in response rate, but actually contrasting with Professor Small's study, the response rate here in the control arm was extremely low. It's only 20%. And that, again, it may just reflect small numbers of patients. PFS and survival were otherwise equivalent, but I did note that the level of grade 3-4 diarrhea was substantially increased from 12 to 25%, and as you might expect, there was a great deal more toxicity. Secondary resection rates were higher with the triplet plus panitumumab, but not significantly so. So I think that when we look at the VOLFI trial, you can see that we can definitely say that if you add panitumumab to a triplet regimen, you increase response rates. The impact on secondary resection rates was quite notable, although not significant. It got very close to it. And I think that from a clinical point of view, this is really very interesting. The response rate in BRAF mutated tumours was also interesting, albeit that the response rate in the control arm was exceptionally low. And there's insufficient data here to draw conclusions about sidedness. I think that, you know, there's the opportunity here to do a meta-analysis of doublets versus triplets, taking all that pooled data together. And these studies very much underline the need that prospective trials need to be designed and adequately powered to analyze the impact of treatments on the clinical and molecular subtypes that we now look at within our clinical practice. And this will better inform us in the future how to manage these patients. Thank you very much.